to start, and thank you very much for attending this webinar. I think that it's quite an important meeting because we can share good practices and other people can learn beyond diseases, but maybe about the management. And so I leave the floor to Sara.
Thank you, Ilaria. Actually, we are so happy to be here today as the previous year. We strongly believe, as members of the network, of the European Reference Network, that sharing something is always something useful for the care process, for the patients, for the clinicians. So we are very happy to help in encourage sharing good practice. Today, we will have some very nice good practice, and we are waiting for listen very interesting things. For the first presentation, I give the floor for a brief introduction to Marta, since the first presentation is made by our two nurses of our clinics. So please, Marta, in the meantime, I will share their slides.
Yes, thank you, Sara. And here I'm presenting this good practice actually as a HCP, not as a ERN coordinator, but it's a good practice that we have in Pisa. So in Pisa, we run lots of dedicated clinics, and some of these clinics that are either run by nurses or strongly supported by nurses. And I really think that the nurse-led clinic is an added value, is a great added value. Maybe our ePAGs could tell us whether this is true, but there are different ways of discussing with nurses and a different way nurses can support clinicians and patients. And Valentina and Sabrina will show you what they do and how they work and how this clinic is going in our hospital. So without other words, I would like to leave the floor. I don't know whether it will be Sabrina, the first to speak, Sabrina Gori, or Valentina Venturini. Sabrina is the person who's in charge with the pregnancy clinic, while Valentina is the person in charge with the wound care at our unit. So I leave it to you.
Okay. Good afternoon. I'm Sabrina. I'm a nurse in Santa Chiara Hospital in Pisa. Now I would like to introduce you my nursing activities in the joint clinic. Pregnancy in women with connective diseases is at high risk of maternal and fetal complications. This is the reason that we have activated a joint obstetrical rheumatology outpatient clinic by incorporating not only medical multidisciplinarity, but also a nursing figure as an essential element. The purpose is to maximize the quality of both medical and nursing services, while minimizing the risks and unforeseen events can happen during pregnancy. The outpatient clinic is coordinated by the experienced nurse who plans the care pathway with patient taking charge in collaboration with the medical team during the weekly briefing. As you can see, the first contact is with the nurse. The first step is always in the nursing clinic. Nurse is able to do a triage to initiate a targeted path based on the disease, on the week of gestation and her medical history. Care planning. Nurse is responsible for bookings, for counseling, monitoring, and postpartum visit. She maintains constant contact with all figures in the pathway. She makes them feel comfortable by introducing herself and listening to their needs. Nurse sets up a file where she collects vital parameters and basic clinic data, like exams, ongoing therapy, and so on. Another important activity is health education by providing useful information on proper lifestyle during pregnancy and postpartum. the importance of control blood pressure, weight, healthy diet, a good rest, physical activity. Furthermore, she tries to understand if there is a good therapeutic adherence, because often, as we know, the pregnant woman is hesitant to take medications. Helpline activity for continuity of care and to satisfy any needs in a short time. And last but not least, the reception of medical prescription. She books examinations and specialistic visits. Clinic performs 3 types of visit every Wednesday from 9 a.m. to 2 p.m. Preconception counseling for patients who want to plan pregnancy. Pregnancy monitoring every 4 or 2 weeks. And postpartum visit around 6-8 weeks after delivery. The nurse is present during the doctor's visit to keep abreast of the clinical conditions and related needs. In this way, the passage of information between doctor and patient is more easy. Visits are performed both in person and teleconsultation mode in selected cases for patients who wish to become pregnant and live far from our center. For example, patients in follow-up without risk of disease or obstetric problems. Patient care begins from counseling to the whole duration of pregnancy up to postpartum. In conclusion, which are the key aspects of the presence of the dedicated nurse? The nurse is essential for coordinating activities and supporting patients in this delicate phase of life. Moreover, the nurse satisfies the basic needs for communication, builds relationship. She is able to capture often unexpressed issues and needs. The nurse, finally, keeps the doctor and patient together by increasing care time. Thank you for all attention. That is all.
It is a lot, Sabrina, at least for me. I think we move to Valentina, and then there is a discussion.
Yes.
Da.
Good afternoon. My name is Valentina Venturini. I am a specialist in home care, and today I'll talk to you about our experience in home care. All we know that ulcers in systemic sclerosis are skin lesions with tissue loss involving the epidermis, basal membrane, dermis, and deeper subcutaneous tissue. They are mainly located on the finger and toes, on bony prominence, or maybe secondary to calcinosis. And these ulcers are a very important problem in the systemic sclerosis for the painful symptom and the disability, and at the cost of the Italian national health system. And for these reasons, it's very important that the ulcers are to be treated quickly through a multidisciplinary approach that includes nursing, whose main goal is to support healing, so to improve patients' quality of life. So in the 2014, born within rheumatology, an outpatient nursing clinic dedicated to the treatment of these ulcers. And this is accessed by all patients with lesion secondary to systemic sclerodermic, and they are followed in our center. And he is evaluated by an in primary. In first, these patients are evaluated by a specialist rheumatologist. After a visit, they enter to our wound care clinic, and the clinic is open daily, Monday through Friday, from 8 a.m. to 1 p.m. And I work in this clinic with my colleague Puccini Carla. During the examination, the specialist deals with the evaluation of the patient regarding the disease, the therapy they are taking, nutritional state of the patient, assess the type of injury present, background of the injury, presence of infection, age, pain, a terrible pain, following the basic concept of wound bed preparation. The specialist nurse decided the dressing to be applied on the wound, schedule all follow-ups. Take care of recording date of the patients, lesion and picture documentation, provide cell information to the patients and caregiver for injury prevention. Patient education is fundamental, is very important. And these pictures is very important, show us that's important putting the patients with ulcers at the center of the care, where all professionals roll around, rheumatology, and nurse care, pediatrics, and radiologists, cardiologists, and infection disease specialists, dermatologists, pneumologists, all. And for a best care, it's fundamental for the patient with ulcers, because this ulcer is very painful, terrible, terrible painful. And so the take-home message, the ulcers in systemic sclerosis are crippling and painful and have a negative impact on patients' quality of life and healthcare cost. A multidisciplinary approach and the specialist wound care clinic are essential for the treatment and the prevention of ulcers. And this is all, this is the end, and thank you for the attention. And I'm very excited, I'm very, si dice, emozionata. Happy. Bye.
Thank you, Valentina. Thank you very much. So just a very small comment, as you see, and as you've seen for the during the presentations of Sabrina and Valentina, really, we believe that this is a good practice that we would like to share, because the added value of the activity of the nurse is great. It is also very important because as clinicians, we are involved when the nurse needs us, and we can offer a continuity to patients, which is difficult for a clinician sometimes because we run from one clinic to the other. So combining the nurse clinic and the clinician, it gives really a lot to our patients. And we believe that in this way we can really be present and feel more needs, really. And so this was the thinking behind the idea of developing these nurse-led clinics, which actually these are two examples, but in our hospital we also have other nurse-led clinics. And I have to say that Sabrina hasn't highlighted this too much. She's a little bit shy, but she is responsible of organizing also the teleconsultation for patients. And in a referral center and as a ERN, we know how important it is to avoid traveling for patients, particularly during pregnancy or in the counseling phase when the referral center is far away. And we want to counsel the couple, and there are issues of working, of traveling, maybe traveling a lot of times, so it takes a lot of time for patients, and Sabrina organizes all the teleconsultation work, because teleconsultation is not just opening the phone and seeing a person, but is be sure that everyone will be there, that the exams will be available the time when we do the teleconsultation. So it is also another great work that they do. And I think that this is a great bridging of different activities around the patient, I would say. And hopefully really around the patient need. And there is another thing that I really would like to highlight for reasons of time, but in the pregnancy clinic, a survey has been done to the patients as to whether they liked the idea of the teleconsultation, for example. And obviously, patients like to come in person to the clinic because they want to see the doctors, they want to be seen, but they appreciate a lot the fact that sometimes they don't need, because for the very short things, there is a nurse that they can contact, or there are doctors that they can see with the teleconsultation. So I don't know if there are questions or things that you would like to ask to Sabrina and Valentina. And Sara is already there to moderate the session now.
Okay. It is always beautiful.
Laurent has a question.
Okay, perfect.
Yeah, I do. Thank you very much. That's amazing. And I do think that it helps improving the quality of care. I'm curious about the number of patients that go through this initiative every year. Can you give us an idea? Is this 5 patients, 15? Is this 50 patients? Yeah, I think it's interesting to know.
I have both here, so the numbers, quanti pazienti all'anno? Numbers for the systemic sclerosis outpatient clinic, pazienti. More than so 1,200 services. That it means that probably they are related to the same patients, but repeated. So I guess probably hundreds of patients for systemic sclerosis. And what about the pregnancy clinic? The number in one here? 700 services.
Yeah, these are very, very big numbers.
Yes.
So there's a true service to the community,
Yes.
I believe.
A huge work, yes, yes, it is. Please, Magdalena.
Thank you. Since we are talking about the best practice, I have some questions to the ladies nurses about digital ulcers that this concern myself actually, and I do have a very good contact with nurses in my hospital in case of wounds that I need to heal. And I would like to ask you, what is your experience, whether it is just wound treatment or is it IV therapy as well that you actually treat the ulcers? And also you mentioned the prevention, so I'm really interested in what details you could mention about prevention of digital ulcers. Thank you.
Yes, I can partially answer together and reply to you. And thank you for your interesting questions. It is one of the crucial points that Valentina daily rises to us as clinicians. Since the process of care in the bound clinic, it's always something that is strictly related with the clinicians involved in the care of systemic sclerosis. And in many cases, she called us to say, okay, probably we need an antibiotic therapy, or probably we need to revise and reassess the immunosuppressive therapy since the patient has an infection, or many other things, such as also IG intravenous immunoglobulin or other therapy. So it is always a unique process, we can say. And regarding the prevention, but probably Valentina wants to add something, I don't know. Many things that I know, since I see her every day, it's the prevention in terms of patient education. She, such as the similar thing is also for pregnancy clinic, but of course for different things. What they do, as many other nurses in dedicated clinic, is to educate the patient. And the education of patients, and this is a point that I know that is very important also for Ilaria and the project that is ongoing, is
don't spoil my comment.
No, sorry. But it's very important in the education of self-management. And this is why I give the floor to Ilaria for comment, but I don't know if Valentina. Okay, the patient education also includes brochure and several other information, also written information that patient and caregiver can learn in terms of patient education. But I give the floor to you, Ilaria, and then to Coralie.
Thank you.
Yes,
I just want to
sure.
mention that we've got a different weather in Poland than in Italy, so that might be also a point. But thank you.
Okay. Thank you, Magdalena.
In terms of prevention, yes, as Sarah said, within the Systemic Sclerosis Working Group, we are developing the project of self-management of digital lesions. Of course, this doesn't mean that a person with a digital lesion wakes up and try to treat the lesion. The aim is to collect evidence, data, and then to develop an article, a journal, brochures, of course, to prevent the development of the lesion into a digital ulcer. So to prevent the pain, to prevent the treatments, to prevent trips to the hospital, and so on. It will take some time, of course, because there is a methodology behind, but maybe next year we can present it as good practice.
Yes.
Thank you. Coralie, please.
Thank you. It's more a comment than a question. Thank you both for the presentation. It's really, really interesting. I just wanted to add that there's also two very important aspects for patients who was a special link with the nurses. The link created makes easy to talk, emotional talk, psychological talk, and so on, and particularly about sexual health, which is really important in certain disease represented here in ReCONNET. And in all cases, I'm sure, and we do have some numbers, that it helps and with adherence, because a patient who can talk to the nurses after the visit with his HCP will ask questions that he couldn't or didn't dare to ask to the physician. So the nurses can be also great support for adherence. Thank you.
Yes, indeed, Coralie, thank you also for this message. Indeed, what we know also from Sabrina, from the pregnancy clinic, is that many patients do not say, and we know very well, to the doctor if they do not take the drugs during pregnancy, especially. Unfortunately, also pregnancy is a time of low or no adherence. But they say all the things to the nurse. So it is a very contact point also for these aspects. Very, very important. Thank you, Coralie. Please, Olga. I think probably also after Olga, also Marta.
Yes, thank you very much for giving me floor. I got a special question because I'm a patient with myositis, and I'm a chair of Czech myositis working group, and I've got several women who were diagnosed with myositis, and I'm very curious as if you have a good results with pregnancy of these myositis women.
Yes, but probably I can give the floor also to Marta for a comment. But what I know is that also dermatomyositis patients are followed by the clinic. But please, Marta, probably you want to.
Yeah, it's a very difficult question you ask, because inflammatory myopathies are rare diseases, and the onset of these diseases is really spanned over the life of the patient. So there are young patients and in their fertile age and outside fertile age. We followed a few patients with inflammatory myopathies. Some patients in the past also with active disease. They became pregnant while the disease was active, and we were successful in, let's say, seeing the end of the pregnancy and treating them during pregnancy, which is what we need to do. I mean, that's the reason why the combined pregnancy clinic is there. Ideally, patients should enter into pregnancy when the disease is well controlled, but you know, the pregnancy clinic is there to support also those patients with unplanned pregnancies. So our experience was good so far. Per se, I mean, it's disease activity that impacts on the pregnancy outcome, basically. So, but there are not big numbers per center, and this is an issue. And I've seen Angela Tincani and Laura Andreoli because it's an issue that is being discussed now all over Europe, because only joint efforts, and the ERN is there for this reason, can give us more data and information on pregnancies in very rare conditions as inflammatory myopathies, and hopefully over the next future we will be able to put together the knowledge and give more strong data on this. And I just would like to, we still have 1 minute for this discussion, and so we will be perfectly on time, just to add this. I mean, this in this good practice, you've heard that Valentina was telling you that we also have brochure, and the brochure are written by our nurses as all the procedures, because it is really their clinic, so it is their point of view to the patient. And about the discussion with the patient, I would just like to leave you with this story. I've been doing the pregnancy clinic for 20 years. Once, and you know me, the majority of you know me, I speak a lot. And once I had a pregnancy counseling with an anti-Ro patient. So I had to explain the risk of neonatal lupus and all these things. And I talked and I talked and I talked. And the couple was there in front of me. They were looking at me, we were talking, and then we ended the visit. And they left and they went to see Sabrina. And then after a moment, she knocked the door and she told me, I think you have to repeat the things, because they told me that they got the point. Are you okay with, yes. When they went out with Sabrina, actually it wasn't true, but they couldn't tell me, oh no, Marta, could you repeat, please? So she came knocking the door and she said, Marta, they need to come back because they haven't, I mean, they need an additional explanation. So I think that this for me was really the point that, as you were saying, Coralie, it is very important really for the discussion as well, but not only, because the support that they give to us, I mean, with these huge numbers we have in Pisa, we couldn't do all the things we do without the nurses and without something that they run on their own. It's their responsibility, but it is a support that we need. Otherwise, we couldn't do all the patients we see. It would be impossible for us.
Thank you, Marta. As you've seen, beyond Laurent, the question came from the patients. This means that we know the value of nurses. We know the role they are playing. And you use the same word I use. They are a bridge. So because really, as other colleagues, my colleagues said, we can tell nurses things we should never tell a doctor. So, and then they come to you as your nurse did and talk beyond the pure disease, but also about the psychological impact, because they are always close to us. For many therapies, we see them every 2 weeks, every month. So if there are no other questions, I would leave the floor to Sara. Thank you so much for your precious presentation.
Thank you. Thank you to Sabrina and Valentina. Thank you so much. It's a pleasure now to introduce another very important good practice. Good practice means a lot of things, means experience, clinical experience, network, but first of all means also explore how to study, how to assess quality of life in rare patients, since it is very important to use tools that are not related to other high prevalence diseases, but also for rare diseases. It is important to measure something related to a rare disease with a measure specifically designed for a rare disease. And this is why I'm very honored to give the floor to Laurent Arnaud, who will present a project on the assessment tool related to quality of life in relapsing polychondritis. Please, Laurent, the floor is yours.
Thank you very much. It's a pleasure as always. It's an honor. I'm going to share my screen. Can you just confirm that you see it full screen?
Yeah.
So that's great. So indeed, I'm going to talk about the development of a new index, new tool to assess the quality of life in a very, very rare disease, but with a big burden, which is relapsing polychondritis. And this is, of course, supported by the ERN ReCONNET. So this is why I'm here today, and I'm very happy. So I'd like to start by a quick question, a challenge for you. Do you know what this is? Well, this is a rough diamond. Maybe you like it like that, but I know many people like it better like that when it's polished. It's more shiny, the price is increased, and this is due to the fact that it has many facets. And you're going to tell me, okay, but what's the point? Well, the point is that it's the care. It's the care of patients that is the same. You can do some kind of rough care, just go somewhere, or you can evaluate in a systematic manner different facets of the disease. And in the field of relapsing polychondritis, I think 3 of these facets are especially important. It's disease activity, its damage, and its quality of life. And with my previous work, we've been working as a group to derive a disease activity index that is specific for relapsing polychondritis. We have also developed a damage index, and now we engage ourselves in the development of something called the RP-QoL, which is really to assess the quality of life. And I must say that RP is a really complex disease. And what we want to achieve with ReCONNET together as a group is to develop a disease-specific instrument for the quality of life in relapsing polychondritis. And of course, to validate this instrument. And the idea is to hear better the voice of the patients. And there's a reason for that. Is that it's a complicated disease. I think Sarah said it very beautifully, it's a rare disease. And so we already have a generic instruments for quality of life, but they cannot capture very well the specific manifestations for that rare disease. So we really need a specific instrument, and this is what we've been working on. It's now been around 6 months. So he started by writing a protocol all together with the group, Laura, Damien, Oliver Sander, Raquel, Lisa, Emilia, Christina, Francesca, Philippe, Sophia, Simona, and myself. So we are a big group in a way. We worked together to write a protocol of what we want to achieve. And it was finalized in February, approved by the Ethics Committee of Strasbourg in March, and approved by ReCONNET in April. And so I'm going to show you where we are, what we're trying to do. It's a difficult task, but I'm sure that we are going to succeed. And I'll tell you why in a minute. And just to show you the idea, what we want to make is a questionnaire to assess the quality of life of patients. It's a self-assessed questionnaire, which means that it's the patient himself or herself that fill in the questionnaire, not the doctor. And so we need to ask questions, but these questions, they have to be according to quality of life domains that are impacted in the context of relapsing polychondritis. So the first step is to list these potential domains. On the screen, it looks very easy, but I'm going to show you why it's so complicated in a minute. And of course, there are many domains of quality of life that we can discuss. But for a questionnaire, we cannot capture all the aspects, so we need to filter these domains. And from these domains, we need to establish questions, such as, because of my relapsing polychondritis, I am unable to have normal social relationships, for instance, that kind of questions. And from that, we will build a pilot instrument that we are going to test with patients, small numbers of people living with relapsing polychondritis, to debrief whether the questions are clear, whether they are specific, and so on. And so the first question I'd like to answer today is, how can we list the potential domains of quality of life that are impacted in relapsing polychondritis? And actually, usually it starts by a literature review. But you know that RP is a very rare disease. So I did this literature review. There's only 20 papers talking about quality of life and relapsing polychondritis. And actually, when you triage this paper, most of them are reviews. If you are talking about original papers, that brings new data, there's only one paper that you have on the screen. And I must say, it talks about patient perception, and it is not fully centered on quality of life. So there are just a few messages about quality of life in that paper. This is just to show you that it is an under-researched area. That field of relapsing polychondritis, there are just a few papers, and there is almost nothing about quality of life. So we really wanted to improve that. So the best way to start is actually to ask the patients. And usually it's done doing face-to-face interviews. But the problem is that it's a very rare disease. And with ReCONNET, we want to work at the European level. And there is not much funding. So it was not possible to start by face-to-face semi-structured interview. And within the group, we found another way, which is to make an interview through an online survey. So this is fully online. It's multilingual. That's a possibility that we can deploy. And we are asking a participant, which are persons living with RP, well, to give us their feedback about the disease, about the burden of the disease. And for that, we had to write a script all together within the group, which was drafted in English. We talked a lot about which questions shall we ask. We discussed with clinical psychologists, we discussed with our ePAGs for wording, clarity, acceptability of the questions. And eventually, after maybe 1 month of discussion, we stabilized a final questionnaire that we want to put online. But as I said, the questionnaire is drafted in English. And as you may guess, many patients do not speak English well, or maybe they do, but to report your quality of life, your burden, you need to do it in your own language. And so what we needed is to cross-adapt the documents in other European language. And I don't know if you've done that before, but it's really complicated. I'll be very brief, but for every language, you need 4 to 6 different translators. You need to make forward translations, to compare these translations, then to make back translations back to the original document, and then to make big meetings to have everybody in agreement. It takes a lot of time. It's really complicated. It's not adapted to a rare disease, and it has a cost. And we don't have that. So we invented altogether a new method, a new methodology to do that within the setting of ReCONNET, something that is more easy. And I'm just going to show you how it works. So first, we needed to talk the same language. So we created a glossary. I'm not going to read it entirely, but it's just to tell you that we agreed upon what the words mean. When I'm talking about a key term, I'm talking about something very specific. And this is this new method. It looks the same or almost the same, but believe me, it is more straightforward, more efficient, and I'm going to tell you why. What we start by doing is looking at the script, at the document, and we find the words that may be problems. So here they are in yellow, everything that is a little bit tricky or could be tricky to understand. For instance, energy, medications, learnings, mental feedback. These words, we highlighted them. And the first step is to ask a senior doctor and fellow doctors, so younger doctors, to check these terms and to discuss between them whether they think there might be a problem between English and their language. So we have one group for German, one group for French, one group for Portuguese, and so on. And these people, they need to be native speakers of French or German, but they just have to have a good enough level of English and to know a little bit about the disease. And this is what we are. We are doctors. We're able to speak in different languages. So it's way more easy and less costly than to find professional translators. And I'm just going to show you, for instance, this analysis for German. On the left, you have the list of key terms that we extracted from the script. And then every color is a different person. And we ask, is the key term existing in the target language? So this is German, and is this interpreted the same? And you see that some people, for some other words, they flagged no. So they discussed together. And well, for German, they agreed upon a translation that they would use for later. So that's a way to ensure that if someone thinks there's a problem, we discuss and we find one word in the language that we are interested in. This is German. Everybody agrees, everybody has discussed. And then we translate. And if you remember, we were supposed to do forward translations, so English to German, and then back translation, German to English again. This takes a lot of time. It's so complicated. And because we have already identified the potential problems with the key terms, we only move forward with a forward translation. And I'm just showing you briefly, three independent translations. As you can see, there are some discrepancies. And again, it's a straightforward process. We discuss, we compare these versions, and we agree upon a reconciliation. One final translation, one final forward translation. So it's way more simple than it was before. And this is the final translation for German. And of course, we involve our ePAGs. So we ask the ePAGs to check, to discuss, to review that everything is understandable. And if it's not the case, we discuss again all together. And this is what we've done. And actually, we are asking for participation of ePAGs as soon as they have a level of English that is enough to be able to participate in this exercise. So this is what we did. We adapted the script in English, French, Italian, Romanian, German, and we started the online interviews. That was 1 month ago, and I am very happy to tell you that many people have participated. For rare disease, this is truly extraordinary. We have, as of today, I checked just before, 220 participants that provided feedback. And I must say that I went through a bit of this feedback, and it really is a little bit sad. It really shows that the disease has a very strong burden. Look at participants 97, all areas of my life have been impacted. Work life, struggle to do things I used to be able to do. Tremendous pain. Really, I think we put our fingers, if I can say so, on a burden that has never really been expressed or assessed in a precise manner before. We are going to use other sources of these potential domains. We are asking an international panel of experts from Japan, from France, Marcella Ferrada from the US, from Japan, from India. So everybody agreed to participate, and most of these people have already been participated. And I'm just going to show you, for instance, expert feedback from Jun Shimizu, who works in Japan. Ear deformities will give you an aesthetic prejudice, which may be a problem with social interactions, and so on and so on. And we have a fourth source, which I believe is really interesting, is ChatGPT. Everybody always laughs a little bit when we're talking about ChatGPT, but we asked ChatGPT which disease-specific domains should be included in a score for quality of life in relapsing polychondritis. Well, I can already tell you that I hope what we will have in the end will be very similar, because ChatGPT did some amazing work. You see that the domains identified are very relevant, and there are some very specific things about body image, self-esteem, about the impact on hearing and communication. That's the point number 4. This shows that, well, the artificial intelligence is somehow able to extract the information from literature in a relevant manner. So that's quite amazing. From these domains, we're going to make, I think, a big meeting all together with the patients, the ePAGs, the doctors, the participants, to filter, to prioritize what is the most relevant. And when we have the final domains, we will start building the questions and this pilot article. We will test it. And again, the questions themselves, the final questions, will be cross-adapted from English to the ReCONNET languages, the European languages. So we are going to engage again in the same cross-cultural adaptation process. So in the end, we will have a questionnaire to assess the quality of life in a specific disease with specific questions that will be validated across European languages. So, well, I'm really happy that we are slowly moving from RAF diamond to Polis diamond and applying that to the quality of care by measuring the quality of life in the relapsing polychondritis. So thank you very much.
Wow, Laurent, thank you so much. As a patient representative, I see the added value of your work, having so many dimensions in under investigation in your survey. And so congratulations.
Thank you.
We love it so much. And we think also that this could open the field also to maybe not tomorrow, maybe not next week, but also to development of new therapies, because having this data can also help in shaping the right and correct protocols.
You are absolutely right. When you perform a clinical trial, you need an endpoint. And for disease activity, we have it. It's the RP-DI. We've been creating that maybe 15 years ago. For damage, which is an important aspect, is the RP-DAM. But you know that it's now more and more important to study, report, analyze the patient perspective in trials. And I think that we are going to get a new instrument to start these adventure, which is complicated, but I'm sure we will succeed.
Yeah, I'm sure as well, also because EMA encourages the use of patient experience data.
Of course, and it's so important to understand better. We talked about the cross perspective of patients and doctors, and that's a way to measure this perspective in a way, in a reproducible manner.
Thank you.
Yeah. Thank you so much, Laurent.
Thank you.
It's really important. It seems easy, but it is not so easy to approach to the methodology of rare and complex disease, especially the specific disease tool for quality of life. So it's a very important milestone for the network, but also for other people.
I'm sorry, I cannot raise my hand. I don't see in the Teams. If no one wants to add things, I would like to congratulate with Laurent also for the methodology. I think that it's really a winning way of doing the things, and I think it's a great methodology that you've set up there. And
thank you. We cannot work with CTDs, rare connective tissue disease, as with frequent disease, and the methods we have for frequent disease, where there is a lot of funding, we cannot apply them. Yes. So it was important that we find a straightforward methodology that is simple, it takes less time, it's more efficient with what we have.
Yes, absolutely. And also reaching patients where they are, because they are also scattered everywhere. So absolutely. I think it's really, I really wanted to congratulate for this.
Thank you very much. Thanks to you. Thanks to ReCONNET for approving and supporting this work.
So if there are no other comments, I give the floor to you, Ilaria, to introduce the next presentation, please.
Yeah, I'm really thrilled and pleased to introduce the following presentation, because it's part of my national patient organization, GILS, and is a ScleroNet, a regional SSC management network. It will be presented by the president of GILS, Paola Canziani, Chiara Bellocchi from the hospital Granda, Ospedale Maggiore, Polyclinico di Milano, and Corrado Campochiaro from San Raffaele in Milan. So the floor is yours, guys.
So I share the slides and then Paola can introduce everything.
Thank you, Ilaria, and good afternoon to everybody.
Can you see my slides?
Yes.
Okay.
Yes.
Yes, I'm
Paola, please.
Yes, I'm Paola, and I'm responsible for GILS, as Ilaria said before, an Italian organization fighting against scleroderma. And we are very glad to present our, I think it's a very important... see, very important goal. We decided to build a network of 5 hospitals in Milan and in the outskirts of Milan. And in these 5 hospitals, we created with helping physicians, nurses, and the administrations, 5 scleroderma units. And these 5 scleroderma units since 2016 have been working together till now. And we've been helping and sustaining them, not only financially, but with our ability to give them some information about patients' unmet needs. What is important for us is to collect patients' needs and inform the physicians that what is important for them, for the patients, but also for the doctors. We are, as an association, a sort of a bridge between patients, between institutions, and I say between doctors to physicians. We presented our network to the institutions in our region, and we are going to present it to the government next June, because in June, there is also a great important day for us, the 29th of June. It's the Scleroderma Mondial, International Scleroderma Day. So we are going to present to the representative of Parliament and the government our programs, and also we are talking about ScleroNet. So thank you for your attention, and I'll give the floor to Chiara and Corrado.
Hi, everyone. I'm very glad to be here. I thank the organizers of ReConnect. I want to thank Paola, our GILS president, but also Carla, our former GILS president, and Ilaria, obviously. So let me know if you see the slides that are going. Okay, so just a very quick slide about systemic sclerosis. So we know it is a chronic autoimmune systemic disease with the multifactorial etiology. It's a rare disease, so the incidence is very low. The prevalence is around between 30 and 450 cases per million inhabitants. And we know that in Italy, 25,000 people are affected by this disease, with 1,000 new cases every year, especially among women. But what is a ScleroNet? So as the title of this organization says, it is a net. So it is a network of specialists that was created in 2016. And it is a network that is focused on systemic sclerosis patients and the complication that can derive from this disease. It involves hospitals from a specific area at this moment, from Lombardy, a very big region in Italy, and is a net that was created with the idea to help patients, but also expert doctors. It has both a clinical and a research purpose. We have now 5 centers involved. So Ospedale Polyclinic of Milano, Ospedale di Guarda of Milano, the Hospital of Legnano, Humanitas Hospital of Rozzano, and San Raffaele of Milano. So all these centers that are involved are main centers that are recognized nationally to be expert centers for systemic sclerosis. And we can say that about 2,500 patients, if we include the very early forms of systemic sclerosis, are now followed by this network in the 5 centers. And these 5 centers cover a very big territory, as I was saying before, so all the metropolitan area of Milan. what is the purpose of the ScleroNet? So I told you that it's for patients, but also for expert doctors. So for patients, for sure, an early diagnosis is the main thing. So if patients are seen by expert doctors, we can try to assure them an early diagnosis, which is very important in autoimmune diseases, but especially in systemic sclerosis. So we are doing great things about early diagnosis now. But another purpose that we have to implement for sure is the telemonitoring. So the idea to try to use the telemonitoring from the hub centers, for example, to spoke centers. In general, our goal will be to improve the quality of life of patients, but also to raise, in association with the GILS, to raise the awareness of the public opinion and institutions, as Paola was saying before, about this rare disease. Another important goal is also to train and update healthcare personnel. So not only doctors, but also nurses, and all healthcare personnel that is useful for the management of this disease. In general, all these purposes, if achieved, and we are trying to achieve them, can save time for patients and also for specialists that are involved in the patient care. How does the ScleroNet works? We try to identify the patients that are the correct candidates to be included in the network path. We organized dedicated agendas among the centers. We tried with these dedicated agendas to reduce at a minimum the waiting lists. And we do recurring meetings that are online or in person to discuss cases that are complex and to discuss obviously also our agendas and more practical things. And as a last thing that is very important, and I want to stress, there is in this network a direct involvement of specialists that are trained in these rare diseases, because we know that not only the rheumatologist and immunologist is important for systemic sclerosis, but it's very important to ask the help of cardiologists and other specialists. And now I leave the floor to Corrado.
Hello everyone, thanks Chiara so far. So I'm Corrado Campochiaro and I work at San Raffaele Hospital in Milan, and with Chiara and the other people, including the ScleroNet. So we created this network, as Chiara was saying. And so I take the step in now, just to say that, as Chiara was saying, it's really important for a complex disease such as systemic sclerosis to have not only the rheumatologist and immunologist looking after the patients, but to have a more global evaluation of the patient. This is why, included in our network, we have some important figures, such as the cardiologists, maxillofacial surgeons, we have the vascular surgeons looking after digital ulcers, we have also ophthalmologists for the sick syndrome that this patient can suffer from, but we also have dermatologists with an expertise in scleroderma, and specialized gynecologists, because of course we know this could be a major burden for our patients, because they can be, of course, young female patients, but not only just for the young female patients, also in the elderly stages of life. And of course, it's really important to have the both the respiratory physicians and the gastroenterologists as well to look after completely our patients. And Chiara, if I can ask you to, thank you. And within the network, so we created also a database, a registry that will offer the opportunity to have a more global look at our patients. And it is called the Observe-Me registry. So this registry belonging to the 5 centers, where we'll have a full collection of demographic clinical data. But compared to other registries, what we were aiming for is to have a more global assessment of the patient. So they will have a specific focuses on the gastrointestinal part, or the cardiology part. So we have the inputs of all the different specialists, and to put together registries will be more comprehensive for our patients. And that's really important because this is also patient-guided registry, so we can focus on the unmet needs that our patients have, and also in terms of the care for these patients. So the importance is to have a global profile of these patients. So we think that thanks to our network and thanks to the collaboration of these 5 centers, they do work really great together. So we really enjoy having time to discuss our patients, to discuss our projects together, and to share our business meetings, the agenda that we want to, ADMs that we want, to have a highly efficient local system that is specialized not only in the care of patients, but also to have a full research agenda developed among the 5 centers. And we think that's really important to have all the stakeholders involved, so with the different physicians, patients, and payers, but also all the different professional healthcare personnel that are involved in the care of SSC patients. And we aim to have also reduction in the cost with this network, because of course each hospital has specific expertise that can be shared among the centers without having the patient lost in between, and that's really important. So we aim to have a reduction in the waiting lists for specific approaches to the patients, specialized approaches, and we think we can add a great value in the research also for SSC patients. So we hope that this pilot project can be replicated in a more global scale, but it's really important to start somewhere. So that's why we started in Milan among these 5 centers. And of course, we are facing some issues over time. So we need, of course, to improve our internal agendas. We're trying to coordinating more among the centers, also about the flow of patients. So the patient can be seen in one center, but the other, we can add inputs from all the different specialists that are more in one center or the other. We want to rely more on the...
no, aspetta, Giorgio, ho sbagliato il numero, aspetta. Perché devo chiedere alla Federica che mi connetta.
To have better pathways with care for patients according to the specific kind of moments. And we are working also on the rehabilitation for patients, so not just on the acute or chronic care, but also a full rehabilitation for all patients. And with this, we thank you all. And of course, we thank all the people involved in ScleroNet and all the specialists among the 5 centers. Thank you for your time.
Thank you.
Thank you, guys, for this very nice presentation. There is already a comment in the chat. And Matty says that ScleroNet work sounds great, but I miss it totally in my hospital. For me, it sounds as a fairy tale. For me as well in 2016, Matty. And what these experts achieved is, let's say, the motto of the ERNs. They shared their patients to care and cure them. Not easy, don't give it for granted, because you know that experts would like to keep their patients and not to let them go into other centers. But this is a form of respect and generosity towards patients, because if you share them with the experts of heart, lungs, and so on, this can make the difference. And this made a difference in this project. And they went beyond, because they really now cooperate and collaborate with each other. And so maybe you can make it also come true in your hospital. We can catch up after the next days if you want some suggestions. And a question for you guys. Did you go beyond the care and looked into the quality of life, the aesthetic part of the patient, the quality of life, sexual life?
Yeah, I mean, this is a great purpose. So this is something that we want to improve and achieve also with the help of the Osservami registry. And the goal of this network is, as you are asking, is to go also behind the usual care, but also going in more deeply into things that are very important for a daily quality of life of patients. So yes, we want to do this. We are trying to do this we are at the beginning of this part, and Ilaria, for sure, you can help us as usual for this purpose.
Yeah. It's thanks to Ilaria that we also collaborate well among us. That's really important to have a patient like Ilaria, involved in the organization of the flow among patients. And that's really true, because we already started like doing some collaborations within like the maxillofacial surgeons to have the lipofilling of the lips, and to have the patients referred not only for aesthetic purposes, but also for functional purposes, because we know that's really important for our patients to have like the full disease looked after, but also what you said about the gynecologists, also to look after the health of our patients from the gynecological point of view, about the problems they can have, the sexual dysfunction they can have. So to have a full look at our patient, not just from like the typical things that we pick up usually in our scleroderma clinic, but like have a full approach to the patient as a whole.
Yeah, thank you. And I know also telangiectasia with the laser therapy.
Yep.
Yes, exactly. So we can add that to have a specialist that really knows the disease on board, it's really important, because they can catch also these other aspects that obviously a rheumatologist and immunologist cannot have time to catch in the visit. So that's why it's very important to this involvement that is open also to other specialists that are not only about lung or gastroenterologists, but also dermatologists and gynecologists.
Thank you very much. Are there any questions or comments?
Just a comment from my side. Congratulations. This is a dream for many other diseases, and sharing this kind of good practice could be something very essential, not only for other countries, but also for other diseases, since a network means something that is related to clinicians, nurses, topic to be addressed, education, and it is a very good practice also for the other diseases. Systemic sclerosis is one of the best examples, as well as other complex, high prevalence diseases in the rheumatological field, but many other rare diseases would need this kind of organization. So let's encourage the inspiration of this network. Congratulations. I don't know, Ilaria, if there are other comments?
No, I don't see any raised hands. So maybe you can go on.
Yes, so we can move to another very important topic, the integration of the ERN system in the national level. And just to highlight the importance of talking about this topic, I would like just to summarize the reason why we are here talking about this. We know that the European Reference Network were launched in 2011 under the Directive of Patients' Rights in Cross-Border Healthcare. And yes, we are here for talking about cross-border, but the European Commission giving this important and huge role of coordination to the all coordinators of the ERN highlighted also how the member states can reply to the integration of the ERN, since ERN means also HCPs, means patient association. So the member states gave a statement for the integration of the ERN, and this statement highlighted how to involve patients' pathway, how to create appropriate network, but also how to encourage the integration of the network in the member state. So we know very well for many years that ERN are cruises, very big cruises, but on these big cruises, there are a lot of smallest boats at national and regional level, but very, very important. And this is why we are talking about how a region or a system can reply to this integration. And for this reason, it's my pleasure to introduce Professor Perilongo, talking about the reply to the ERN process. Please, the floor is yours.
Thank you very much. Can you hear me?
Yes, very well.
Okay. Well, let me start sharing my presentation, if I may. Can you see it?
Yes. Yes.
Can you? Okay. Can you? Yeah. Okay.
Not the presentation version, but we can see. Oh, yes, perfect.
Okay, and if I move on, you see also the next slide? Yes, okay, so let me start. First of all, allow me to, thank you for having invited me to this meeting, and I do apologize if I've not been here with you since the beginning, but I am traveling at the moment, and so I just have the time to connect with you now, and so I apologize for that. First of all, I present myself. I am a pediatrician. I am the head of the pediatric clinic and the departments of both women's and child health and rare disease of the University Hospital of Padua. I am the healthcare representative of the ERN transplant child, married, 2 children, 2 grandchildren, and getting old. Okay, let me move on and say, what is the University Hospital of Padua? I hope you can see the proceeding of the slide. Just to be very simple, it's a very large tertiary care academic hospital, which in itself encompasses also a very large children's hospital, a 330 bed of a children's hospital. And it is involved, it has been involved on the rare disease since 1992. I don't want to go through all this next slide, but just to say that it was in the early 90s that the pediatric department identified rare disease as a field along which to develop. So just to say that we have a sort of a long history. Few notes of background. The inspiring concept, which is all behind what I'm going to present, is that the leadership on rare disease is also an institutional issue. I translate immediately what I mean. Concepts such as diagnostic odyssey, I don't know if pronounced correctly, complexity, multidisciplinarity, innovative therapy, comprehensive and continuity of care, transition, patient and patient association empowerment, communication with the stakeholders of the rare disease ecosystem, the concept which dominate the field of rare disease, thanks to political and strategic decision and adopt developmental plan and appropriate instrument, should become objective from an institutional point of view of a comprehensive institutional educational plan in order to develop a diffuse culture within the hospital of rare disease, specific professional competence, objective for developing uniform guidelines for common procedure like transition, telemedicine, or for innovative organizational solution, or for infrastructural investment. And from an institutional point of view, rare diseases, not only the ERN, are a disruptive innovation, no matter what. There is a lot to be done there is a lot that needs to be done in order to make the institution suitable to provide comprehensive care to patients with rare disease. Within this picture, which is the background, the culture of the ground, which dominated the scene of the University Hospital since the beginning, let us say, of this millennium, between the 2017-19, like everybody knows, the ERNs came along, and the University Hospital of Padua found itself, I use this way to tell you the story, healthcare provider of 22 ERNs, which was the consequence that for the first time, not just the single professional, the single big professor, not even the single multidisciplinary equips, but the entire hospital found itself projected into a large European panorama. From this consideration came along the need to be present in this international panorama with just a singular structural and functional profile. And this need became paramount important in face of the fact that the University Academic Hospital of Padua is the health care provider of 22 ERNs. So with this background, in 2010, the University Hospital of Padua decided to launch the Department of Rare Disease. I will be brief. will take a lot of time, but for this department is a combination of a lot of services of this big hospital. I don't want you to read, but we set our vision, our mission, our values, and furthermore, that is, I know that is an unreadable slide, but just to say that we decided for a 3-year developmental action plan, which includes a specific objective, strategies to achieve this objective, indicators, a time frame during which to develop these strategies. In 2023, like everybody else, we were involved in the ERN evaluation process, so in the evaluation of our contribution to the various ERNs we were part of. And that's what I will present now, focusing on what has been called the Padova model. Those are the 22 ERNs, sorry, it's not visible, the last one, but only 18 underwent the evaluation 2023, because those were the ones who were being activated since the very beginning, so who had 5 years of living. I guess you all know, so I will be very brief in remind you what was all about the evaluation process. It was requested to every single healthcare provider to fill up a self-evaluation form, questionnaire, which was based on 64 items. So the University of Padova, being part of, at the time, 18 healthcare ERN, had to complete 18 self-evaluation questionnaire. The step 2 of the evaluation process was to have those questionnaires evaluated by what it was called an external evaluation body, and the entire process, like you all remember, was completed by a releasing of a final report to each healthcare provider. I mean, for us, to the 18 ERNs for which we are healthcare provider, in terms of scores and in terms of recommendation. In face of this procedure, we, University Hospital, decided just to speak with a single language to coordinate the filling up of the 18 self-evaluation questionnaires, which were sent to the 18 representatives of the 18 ERN, of which the University of Padova, of the University Academic Hospital of Padova is a member. Then we decided to analyze in a comparative fashion and then to summarize in a single document all the scores and comments which were included in the final 18 report that we received. And the step 3 that we set up was to elaborate a quality improvement plan for the entire University Academic Hospital. So that in details what we did. Initially, we look at the requirements. You mean we look at the 64 items composing the self-evaluation questionnaire, and we identify those items through the 18 ERN that deserved an answer coming from the hospital and not from the single representative. Then we move on and we decide which offices of the university hospital has to provide this common answer. So we identify which office, which documents were necessary to support the replies, and which data to produce in order to satisfy the requirement that were requested. Concurrently, we ran on a regular basis, on a weekly basis, regular meeting with each of the 18 representatives of the 18 ERNs of which the university hospital is a member of, in order to make sure that everybody was accepting the role of waiting for those replies that were needed to come from the hospital to fill up the questionnaire. And finally, we come up with the document. So we set up a system where rare disease department was making the machine running and involving a series of offices: the educational and training office of the hospital, the data monitoring office, the Clinical Research Office, the Medical Quality Office, the Communication and Public Relationship Offices, and the ERN Office, all working together to provide a reply to the questionnaire that were submitted to us. Bottom line, we came up with this document, and I will go very quickly through this document. Well, essentially, we describe what was the process, about, and then they report the result. As you know, for each healthcare provider, there was a score which reflected how well we replied to each of the 64 items. That was it. And then what we did, we looked items by items, but also to the sub-items included in each of the 64 items, and we put in a comparative way the score received for each specific item according to the 18 different ERNs that we were part of it. And we come up with the final score. The score went from 0 to 2. We use a coded colors, meaning use the green to say that we are doing okay, using the orange to say so and so, and the red to say in this area we are doing very poorly. We combine these scores also with the written comments that we received regarding the outstanding practice that we had in place, the strengths, the barriers, and the suggestion for improvement. Finally, what happened, what we did with all these things? It helped us to provide what is called the 3-year quality improvement plan for profiling more and more our hospital as an outstanding hospital for patients affected by rare disease. That actually were the recommendation coming from the European Commission to use this evaluation as a tool to set up the so-called act, plan, do, check, and act. Very briefly, what was the final result? What the final result that we have launched, and we already started 2 months ago, a 3-year highly articulated professional course, including some homework and a lot of teaching section in classes in rooms for the hospital staff involved in the ERN. We gave this title to our 3-year highly articulated professional course. We titled Working Together as an Opportunity for Innovative Leadership in the Field of Rare Diseases. And the 5 areas where we are working now are in improving our role to favor patient empowerment, so the relationship with the patient. The second area is the relation with patient associations, the implementation of best practices, in particular transition, for which now we have developed an added-on program just focused on transition. The area of improvement was the telemedicine, and the 5th area that we decide to invest in to develop what we call the culture of the data. We doctors are producing a lot of data. We're filling up the registry, but we need to produce clean data in order to have excellent results. Bottom line, what was the opportunity that all this process made us available, and we took it? First of all, to implement a diffuse culture of the ERN. People were not too much aware of what the ERN were all about. So it was an opportunity for creating this diffuse culture to set up an official office for the ERN, sorry, it's written in Italian, but the ERN office, to diffuse a culture of rare disease in general. So implementation of an institutional view on rare disease management that involved everybody. And also, we engaged the hospital staff in an advocacy role towards the CEO of the hospital. And finally, we set a website for the I concluded. Fundamentally, we consider the evaluation process as a sort of international institution accreditation process. And we come up with this decision. Let me go back to the start and say, the inspiring concept about the leadership of rare disease and institutional issue. Well, the University Academic Hospital of Padua has excellent managers running the hospital, but they are distracted by too many commitments. And bottom line, they do not know a lot about rare disease and more specifically the ERN, which brings about the concept that we, doctors, nurses, or the people involved in rare disease management, we need to play an advocacy role in favor of rare disease towards the manager of the hospital and the manager of the health system in our region. So bottom line, and we do that not only because we believe that rare diseases are important, but because we also think the rare diseases are in some way paradigmatic of how the medical practice is going to go. Well, that's all. I hope to have been able to communicate it to you, to present what is the Padua model to deal with the ERN and to project ourselves in the future, particularly in the joint action for Jardin. I do apologize for not being able to have been with you since the beginning. I thank you, Marta, and I thank you all. Thank you.
Thank you, Giorgio. May I ask you to share the slide of the different offices engaged, the one with the ingranaggi?
You want to see again?
The slide.
Yeah, do you want me to project again?
Different offices
okay.
Involved, the one with ingranaggi, because I think the secret is there. And as you said, the being first in 18 ERNs and then in 24 ERNs is the result of a vision that your region and your hospital have. Not all the regions are so sensible towards rare diseases. And I'm really sorry that today the right persons to address your message are not here, the CEOs, the general managers. You have...
Oh no, God, I don't know. Okay,
no, that was the slide.
Okay, let me try again.
Oh, it doesn't matter, Giorgio. I think that having a hospital dedicated to ERNs should be mandatory for hospitals that have more than 1-2 ERNs, because clinicians, doctors can't do all the bureaucratic stuff. You see, you made the good job of advocacy, but then on the other side, you need to have a person that is willing to listen to what you are saying and to understand the added value of being within the ERNs. In my personal experience with the hospital I collaborate with, I don't see this strategic vision. And so this is amazing, but I think this didn't surprise us, because we know that Padova...
don't say so.
Yeah, since 2017. So I really would like to address this need to the general managers of the hospitals. So thank you again, Giorgio.
Thank you to you. And please, I need to apologize, but I need to leave because I have to run to take a plane. Sorry, it happened. That is just a coincidence. I'm not a too busy person. I am a normal person, but sometimes I made a bit of confusion with my life. So please apologize me. Let me run away. I will be pleased. I mean, it has been an honor to be with you. Thank you, Marta. Thank you, Ilaria. Thank you all.
We will have time to discuss when we will meet in Rome, at least.
Absolutely, absolutely.
Thank you very much.
Thank you. Sorry to leave. Sorry.
Thank you. Okay, thank you. Ilaria, I give the floor to you to present the next and last presentation of today.
Thank you, Sarah. Yes, it's my pleasure to introduce Doctors Guichou and Foy, sorry for my bad pronounce, and they will talk about practical guidelines for the diagnosis and management of the non-vascular Ehlers-Danlos syndromes, because we know there are many EDS syndromes. The hypermobile form is within our ERN. The vascular form is in Vascur, and I don't know if it's in other ERNs, but this means it's a very complex condition that involves several organs. Thank you for your presentation. We have here also our ePAG from EDS, Eva Collado Gonzalez, and her cat.
Thank you, Ilaria, and good afternoon to everyone. So I am Dr. Karel Benistan. I am head of the French Reference Center for Non-Vascular EDS in the HCP Raymond Poincaré Hospital in Paris region. And today I will leave the floor to Malika and Gabriel, who are project managers in my team. And so they will present you the French practical guidelines for the diagnosis and care management of non-vascular EDS. Thank you.
So let me share the screen. Okay, so now you should be able to see my screen. And tell me if you can see. Okay.
Thank you.
We cannot hear actually.
Can you hear us now?
Yeah, perfectly.
Okay, thank you. That's really nice. So, hi everyone, I'm Malika Foy. Thank you for the invitation of this beautiful afternoon. So to start the presentation, I will make the definition and present some basics of what is this for French practical guidelines for diagnosis and care for rare diseases. And then Gabriel will make a focus on the French practical guidelines for Ehlers-Danlos syndromes. Sorry. To start the presentation, I just would like to share with you a quick reminder on the organization of rare diseases in France. Since 2005, the French Ministry of Health has launched a series of national plans to structure the organization of care for rare diseases. These actions allow the creation and the labelization of networks of rare disease reference centers, such as, in our cases, of course, the creation of the reference center for non-vascular EDS, which is currently composed of 13 centers located in different hospitals across the country. This network is coordinated by Dr. Benistan. It is important to know, these plans also allow the creation of rare disease health filière, which bring together actors from different rare diseases. It is similar to the system of ERN, but on the scale of a single country. Non-vascular EDS reference center network belong to the OSCAR filière. Now, it is important to know that reference center have 5 missions: the mission of care and diagnosis for patients, the mission of expertise. They have to contribute to research and training, and they coordinate the care at the national level. To respond to this mission, a reference center have to develop some action, and one of these actions, and which is also mandatory, is the elaboration of practical guidelines for the diagnosis and care for rare diseases. These practical guidelines are called in French Protocole National de Diagnostic et de Soins. And as its name suggests, this is a document of best practice guidelines designed to improve the diagnosis, the care, and the follow-up of people suffering from rare disease in France. These documents are composed of 3 independent documents: the practical guidelines itself, the summary for the general practitioners, and a scientific argument. These documents have several goals. They are here to inform healthcare professionals about the best diagnostic management, the optimal treatment, and care pathway for a rare disease or a group of rare disease at a given time. They are also here to try to optimize and harmonize patient care pathway across the country and its overseas territories. This point on my mind, it's quite similar to the ReCONNET project concerning cross-border clinical practice guidelines. These French guidelines also serve as a reference for GP when setting up the care management plan, which can be done in consultation with a specialist of reference centers. It can also be used to cover treatment or to identify medical specialties or treatments that are necessary for patient care, but are not usually reimbursed by the national health system, also known as Sécurité sociale. It also allows to distribute drugs that are not specified in the marketing authorization for a given disease. On this slide, we summarize the different players involved in the elaboration of the French guidelines. The guidelines are developed and written by experts from reference and competence centers in accordance with a specific methodology defined by the National Authority for Health. Gabriel will present to you this methodology in the next slide. Then patient organization could be involved in the proofreading of the guidelines. This work could be supported by the health filière, which in this context, they could finance the project and provide logistical support. And at the end, the guidelines are published in open access on the website of the National Authority of Health. And in some cases, this institution could carry out methodological quality audit. Now, I leave the floor for Gabriel.
Yes, thank you, Malika. So now let us dive in the methodology of redaction of those French practical guidelines for rare diseases. So this content, as Malika said, is provided by the National Authority for Health, and it allows that the methodology is the same for all rare diseases in France, ensuring comparability between the diseases in the methodology. So this methodology is based on the search for scientific evidence in consultation with all the stakeholders concerned, taking into account existing French or international recommendations. It details the main steps of the project, from its definition and the declaration of intent, the drafting of guidelines, scientific arguments, the multidisciplinary working group meetings, the finalization and distribution, and also as practical guidelines give recommendation at a given time, as Malika said, it is highly advised to update them regularly in line with new scientific breakthrough. So an update should be considered every other 5 years. So it's not mandatory, but one should consider it every other 5 years. Here, as you can see here, we have all collaborators for our guidelines, the non-vascular EDS guidelines. You can see this large working group actually as non-vascular ileoidal syndromes are connective tissue diseases with multisystemic complications. It was necessary to involve several medical specialties, 22 medical specialties and 52 experts, with geneticists, many surgery specialties, pain specialists, etc. All the experts from the different specialties analyzed bibliography regarding their own expertise and helped to build specific content. Now what's covered by this guideline? In practice, the content details the care pathway starting from the patient diagnosis until the follow-up of the patient. It contains recommendations and precautions, but also contraindications and obligations. So we can find the definition and classification of non-vascular EDS, the clinical manifestations, the content of the multidisciplinary initial assessment with radiology, biology, paramedics, etc., the genetic diagnosis with genetic indication, genetic counseling, pre-implantation and prenatal diagnosis, the need for psychological consultation, which is highly recommended in France for positive genetics in rare diseases, and also some interesting chapter, which are the recommendations by medical specialty, because actually this is a 76-page document, so it's not designed to be read at once. And usually the specialist will fetch information in their own chapter when they need it. So they will fetch, for example, for gynecology, there's a few content for gynecology for one EDS, hypermobile EDS, for example. I can go to this information, get what I need, and go out. And finally, there's also patient follow-up and description of care network and of the patient organizations that are also involved in the redaction of the diagnosis. This content is also approved by French college and societies, which gives more credibility to those guidelines. For us, the content was approved by Pain Management Society, Physical and Rehabilitation Medicine Society, and Internal Medicine Society. So now we will see how to access these guidelines. The distribution of these guidelines is done by the National Authority of Health on their website, but also by patient organizations who help work on it, but who can also distribute it. So there is a website, you can find it on the website, but there's also a booklet that I have here that was done by one of the patient organizations. And in France, we also present it during congresses. So let's check it out. You have here QR codes to search for all practical guidelines in this French website, and this QR code will lead you directly to the non-vascular EDS practical guidelines. So if I leave the presentation here and follow the link, I get to this page, and here you can find, so you're on the Haute Autorité de Santé, which is National Health Authority website. There's an English version available, but in the English version, this page doesn't exist yet. So that's why I am on the French version for Protocole Nationaux de Diagnostic et de Soins. And as you can see, you can look for practical guidelines, PNDS, you can go through the list and fetch a name. There's indication of the date of publication with a color. If it's dark green, it was published in less than 5 years. And if it's light green, more than 5 years. So if we look for Ilaria dans l'os, we have Syndrome d'Ehlers dans l'os non vasculaire. And you can see that it was published in 2020. So we get then to this page, and we find a short explanation on when it was done and how it was built. And we have the 3 documents that Malika presented you: the synthesis for a general practitioner, the document, and the scientific argumentary. For example, if I open the synthesis for general practitioner, I can find a 4-page document that's adapted for general practitioners with information for all kinds of non-vascular EDS in their follow-up with their general practitioners. So if I go back to our presentation, I hope you can see my screen well. We showed you how to access this content for now in French. So how could you use French practical guidelines as a member of the ERN ReCONNET? To us, it might be useful in two cases. First, it might be a thinking tool to build a methodology for European good practices. Indeed, this methodology is perhaps more adapted to France than to Europe, but it could serve as a working tool and not as a basis, but as something to food our thoughts and to give a good point of view on what methodology we could have. And the second point is the medical content, because we can directly share the medical contents and the medical guidelines that were provided in these documents with our European partners, and meaning doctors, physicians, and patients. That's what Professor Arnaud, who is here with us today, did in his webinar with ERN ReCONNET. So I invite you to go and see his webinar if you haven't seen it yet, because he presented many aspects of relapsing polychondritis in this webinar and allowed patients to have to ask questions, which was a great intervention. So the next step for us now is international distribution. We are currently working with the aim to publish a summary article in relation with these practical guidelines. This work is a work in progress with the French non-vascular Ehlers-Danlos syndrome network, and we hope for it to end and to have a publication by the end of 2024 in a scientific journal. So we will inform you when it's finished. And finally, for an idea of how it could be used for the case of EDS in particular, I would just like to end with a reminder of this article that was published in 2018 by some members of this ERN, and to show you that there was a complete lack for evidence-based clinical practice guidelines, and they found 0 articles with clinical practice guidelines based on evidence in all literature. So if for now there is still not any evidence-based guidelines, we can use these French practical guidelines as a starting point or as somewhere to fetch information, waiting for these evidence-based guidelines to be created. So I'm sure that even though this is limited to Ehlers-Danlos syndromes, the lack of evidence-based clinical practice guidelines also concerns other diseases for the ERN. So I hope you can find some help in what we presented today for your own disease. And finally, I would like to thank you all for your attention. As the last speaker this afternoon, I hope you still had energy to follow this presentation. And thanks to all my team for the help to these presentations. Thank you all.
Thank you so much. Thank you so much. This is a very great presentation regarding, as you say, something that is related to one disease, but probably maybe apply the general approach of the other disease. And I would like to highlight how this is important in our network, since, as Ilaria said before, the principles of the European networks are to share or to improve the knowledge when we do not have evidence. So it is really important to try to disseminate what we already have, and it is really important to try to identify an approach for improve the adherence to the guidelines. That is one of the main topics that we addressed in the first 2 years of ReCONNET, and checking in the network why we have problem in applying clinical practice guidelines, highlighted a lot of challenges from the patient's point of view, from the clinician's point of view. So your work is something, and the approach for the translation, for example, on what Laurent presented together, these action and these activities can improve these aspects and fight against the challenges that we have in the network. This is why the networks are here. So thank you so much. Thank you.
Thanks to you.
I don't know if there are other comments.
Coralie and Eva.
Coralie, sorry.
Yes, thank you to the French team for this presentation. It's a comment. I just wanted to say that in France, with the different PNDS that are already existing for disease, including Sjogren's disease, we don't hesitate to recommend to patients to print out the summary intended to GPs and possibly give them to their doctor, GP or specialist, because obviously every GP in France doesn't take the time to consult PNDS for every rare or low prevalence disease. So we actually give that to the patients and say print them and give the smaller pages and give them to the specialist. So thank you for this presentation, the French one.
You're welcome.
Thank you.
Thanks to you.
Thank you, Eva, please.
Thank you very much for this presentation. And I totally agree with Coralie, and it's actually linked to what I wanted to say. This kind of documents, especially now speaking of EDS, since there were no clinical practice guidelines before, are going to be so paramount for the patient community, because we lack this, because actually we recommend patients to print out any sort of information they have when they go to their specialist. So reading that you're going international with it really gives us hope, because in those countries where we don't have the luck yet to have this kind of guidelines, it's going to be very, very helpful. So first of all, my congratulations and my thank you. My second question is, you have written a document for general practitioners. How do you approach general practitioners? We are working on that from our patient organization right now, but we find even when they are open to it, they acknowledge that they don't have the capacity to deal with it. We from our patient organization role try to give them a glimpse. We are not doctors, but we try to give them a glimpse of scientific articles, clinical information, so they can recognize a bit. But ideally, this gap should be filled in by the system and by doctors. So what is your experience with that?
We have several experiences. The first one is that we have been helped by Social Security to transfer some documents to GP on these pathologies, because it was a problematic issue in France. The second one is that we are organize a webinar for GP and for physiotherapists, and we propose to our patients to communicate the date to their GP. And after, it's true that a lot of GP are very busy and can't be very interested to all rare diseases, but often they are interested, and some of them participate to webinar and to special days in the we have one day per year on EDS subjects, and they are invited to participate too.
Thank you very much.
Thank you. Laurent, please.
So thank you very much for this initiative. I think this is really, really great. Sometimes there's no good evidence, good recommendations in the literature. And I think when we studied that with ReCONNET 2 or 3 years ago, we've shown that for several diseases, there was actually nothing. So it's great that France has started. Very happy with this. It could be another country, that doesn't matter. The way the PNDS, the French PNDS, are organized is that everybody is writing a little chapter and then people are discussing all together. But that is quite different from the usual methodology for recommendations. And so one idea would be to take the big chapters, the big messages from the PNDS, to turn them into statements, and then to have a kind of formal vote, approval within ReCONNET, just to have very formal recommendations. I think that can be done very easily with little effort, and it could bring much. So it's just a suggestion.
Yes, a very good idea.
Yes, I have to follow this. It's a very good idea. While they were presenting, I was thinking how we could really integrate the activity that is already there with what we are doing, because we don't want to reinvent things. I mean, it doesn't make any sense.
We have a great group of great people. So making statements, discussing a little bit about the statements, and then voting, like a Delphi survey or something. It could be some formal ReCONNET recommendations.
Yes,
you know,
some point to consider or something, yes, is needed, and particularly because there are very little data. I can see Eva, but I can also see Marco Castori here, who is really an expert, and so I really, you read in my mind. I think that the moment the group will be rebuilt, we need really to start with this, and this would be a great starting point because a lot of work is already there, so it will really be great. Yes, absolutely. It's a great idea. Yeah.
Are there other comments? So congratulations again. I give the floor to Marta for some comments.
So Ilaria was actually moderating with Sara, but she had to leave the meeting because she had another commitment. So now I'm Marta, the coordinator of ERN ReCONNET, just to say that I'm really so happy of this event. It was amazing, as it is always when we share and when we listen what the others are doing. And because, you know, one idea could be then used for other diseases. It's like a contamination that is really, really very important for us. So thank you to all of you for participating, for asking questions, for sharing your experiences. And I believe that this was again a great webinar. And we also are on time almost perfectly because we started with a 10 minutes delay and we are ending almost on time. So it was really successful. Thank you to all of you. And Sara, I leave the floor to you.
Yes, thank you. Indeed, it was a very positive contagion of good practice. As we discussed it in the framework of the research working group, we planned so far to have an yearly event, but if we need, and we think that probably twice a year we need to meet and share other experience, we can do it. It is really important, and let's think about the next good practice to be shared. So thank you again to all of you. Thank you so much.